Excellent. I'm John Flanagan. I work at the Center of Global Health, NCI, and I'm one of a handful of government employees that has coordinating NCDs in a job title. And I think I seek sympathy for that, but it is a very interesting job because it allows me to introduce people to each other who should know each other. And that's really been a theme of this conference since year one. When we were first conceptualizing it, we actually jokingly said it was speed dating. It was a chance to introduce people interested in global health to people interested in cancer and find how many connections we had. It was a chance to introduce people who think of addressing cancer at a population health level to people who think of addressing cancer on a one-by-one bedside level. And this year, it's a fascinating opportunity to knit together people who think of cancer and people who think of technology and realize how much we have to learn from each other and what potential there is to address the future needs for an accurate diagnosis and effective treatment for cancer in the global health world. In the way of expanding our list of acquaintances, I have the pleasure of introducing Tom Bollyky. And Tom Bollyky comes to us from maybe a different route than many of us who come from healthcare and science, but he has had huge impact on addressing attention to the emerging global health crisis of non-communicable diseases, and there are stacks of his books around, which is quite remarkable for a technical report. It's in a second printing and has been very interesting for a lot of both people interested in global health and particularly importantly, many of the people who have to look to funding global health. Tom's a senior fellow at the Council for Foreign Relations. He has a career that has included working at the U.S. Trade Representative. He's been a Fulbrighter in the Republic of South Africa. He's presented cases to the International Court of Justice and the U.S. Supreme Court, having had a BA from Columbia and a JD from Stanford. He has been published in sources that many of us would not think about as being science leaders, including the New York Times and Foreign Affairs magazine, but he's also been published in Science. So he is a man of many accomplishments, very thoughtful, and today he's going to talk to us not so much exactly about what's in this excellent read, but his strong interest in frugal technologies and the possibilities for reverse innovation, recognizing that as we all work in global health, we need to continually revisit the questions of why and what's in it for the American population. So it's with great pleasure that I introduce Tom Bollyky.
Great. Well, thank you very much for that kind introduction. It's an honor to be here and speak to you all. Let me see if I can manage to make this work. There we go. So why is the Council on Foreign Relations interested in cancer? For those of you that don't know the institution, it's a membership organization, a think tank. It was started in the aftermath of World War I. By Elihu Root, a Nobel Prize winner, also former Secretary of State in War. It has traditionally focused on foreign affairs and has launched the careers of many Secretary of States and some presidents. It is moved into global health about 2 decades ago, focused on really issues of national security related to global health, so pandemic influenza, HIV. So why would we be interested in cancer and other non-communicable diseases in low and middle income countries? One thing the Council does is we do task force reports. We don't do very many. We've only done 72 in our nearly 90-year history. They're typically led by former US presidents or Secretary of States. Our first, let's see if I can, there we go. Our first task force report devoted to global health was actually the one that sits before you now, and focused on non-communicable diseases in low and middle income countries. It was led by, or chaired by Tom Donilon, who was President Obama's national security advisor during his first term, and Governor Mitch Daniels, current president of Purdue University, former head of the Office of Management and Budget during the Bush administration, but also included a wide range of figures that are going to be more familiar to this audience, former heads of the Department of Health and Human Services, several leaders of the CDC and former Surgeon Generals, former national security advisors, even by the standards of some of these task force reports. It was an excellent group. By and large, people who had not spoken out about non-communicable diseases in low and middle income countries before. We asked them several questions, and I'm going to draw a bit on that report as well as some additional information. The first question being, are non-communicable diseases, are cancers and non-communicable diseases in low and middle income countries an emerging crisis? Is this something to worry about? The second question we asked them is, why should the United States care? There are a lot of problems in the world. The US certainly doesn't address many of them. Why should we be interested in this one? And the last question, which is particularly pertinent to this audience, is if it is a crisis, if it is one that the US and other donors should be interested in, what is there to be done about it? And specifically for a group like this, what is there to be done by the private sector and the academic community in playing a leading role in doing something about that? So to take the first question, are non-communicable diseases in low and middle income countries an emerging crisis? To do that, we looked at what the burden looks like in low and middle income countries, and this is what it looked like around in 2013. It is different than the burden from non-communicable diseases in higher income settings. You certainly see a greater burden to cardiovascular disease in low and middle income countries, but cancer is not that far behind that. It is the second leading cause of death from non-communicable diseases in low and middle income countries. And what we found is not only is there a burden, it looks different in other ways, in that it is rising faster in much younger populations and having significantly worse outcomes than we've seen in higher income settings. How fast? Between 1990 and 2013, deaths from non-communicable diseases, including cancers, increased 53% in low and middle income countries. That's nearly twice the rate of population growth in those countries. It's not just increasing fast, particularly some cancers are leading the way. The rate of breast cancer disability-adjusted life years increased over 100% in low-income settings. And if you go down the various cancer groups, you can see a really dramatic increase within those that isn't matched by what we've seen in higher income settings. It's not just increasing faster, it's also increasing in much younger populations. When the World Health Organization thinks of premature, they think of 70 and younger. We actually took a stricter standard. We did that for a couple reasons. One, we thought it would be more persuasive as a policy matter, but also we wanted to be younger than the average life expectancy of any region in the world. So we took 59 and younger. And what you see in sub-Saharan Africa and South Asia and some other countries, it reaches as much as 80% of the death and disability from non-communicable diseases happens in people under 59 and younger, so much younger. It's not just increasing faster in younger populations, it's having significantly worse outcomes. Cancers that are largely preventable, like cervical cancer, or largely treatable, like many children's cancers, are death sentences in lower income settings. So what? It's increasing. We're seeing a demographic and epidemiological transition in lower income settings. Isn't this a sign of progress? Isn't it a good thing that people aren't dying of malaria anymore? Isn't this a sign of rising incomes and progress? Well, what you find is the rate of increase from non-communicable diseases is significantly faster than the rate of decline from communicable diseases. It is 300% faster in low-income settings, It is a third faster in lower income countries. It is not as tied to changing lifestyles as you might think. Certainly there's an increase in, let's just take obesity as an example, certainly there's an increase in obesity in lower income countries, still really low in comparison to high income countries. So the adult prevalence of obesity and overweight populations in low income countries is 5%. The adult prevalence in lower income countries is 7%. In the United States, as you may know, it's 35%. Orders of magnitude different. So if it is not just being driven by the decline of communicable diseases and the adoption of unhealthy lifestyles, what is playing a factor here? And what we found is it's much more tied to poverty than you might think. This is the size of the circles here, of course, is the degree of burden from the disease depicted. How far along you are on the x-axis shows what percentage of the overall disease burden it is in that country. This is from a health affairs paper that we recently put out. And what you find is the tie between economic development, poverty, and non-communicable diseases is stronger than it is for many of our current global health concerns. So for instance, stomach cancer and cervical cancer have a greater tie to poverty than HIV or dengue. So what is driving this? Well, what's driving it is that we've seen which is good news, we've seen a transition. Fewer infants and children are dying. But that increase in longevity and those improvements in child mortality have not been accompanied by the same benefits of personal income growth and health system spending that you saw when higher income countries made this transition. So when high income countries reached an average life expectancy of 59, which happened way back in 1946, the GDP per capita in higher income countries was $4,400, the average GDP per capita. When lower middle income countries reached that threshold, which happened more recently, it was 2,000. For low income countries, which just reached an average life expectancy of 59, it's 1,000. So significantly poorer in terms of the ability to pay for healthcare out of pocket. At the same time, we've seen some increase in health spending in lower middle income countries. It's actually tripled in the last 20 years, which is good news, still really low. All 54 countries of sub-Saharan Africa spend about as much on healthcare as the government of Poland. All low and middle income countries, representing 4.7 billion people, spend the same amount on healthcare as Germany, the United Kingdom, Canada combined. Still really low. And the combination of poverty and the inability to pay for services out of pocket and the limited expansion of low and middle income country health systems into chronic care and spending is part of why you're seeing this rapid increase of non-communicable diseases outpacing, for instance, what you see happening on the communicable side. There are also other factors as well. You've seen rampant urbanization, unprecedented rates of urbanization, and that's certainly playing a factor. That rate of urbanization is fastest in Africa and South Asia. This is not what you think it is. These are not mega cities of 10 million people. Most of the urbanization is happening in cities of 1 million inhabitants or fewer. Cities that don't have a lot of infrastructure, certainly not healthcare infrastructure. And you've seen some increase in modifiable risk factors in low and middle income countries. That's particularly true for tobacco. Tobacco consumption in low and middle income countries between 1970 and 2000 tripled. All right, so at least according to this committee, this felt like an emerging crisis, something that should be concerned about. Why should the United States or any other donor care? Again, there are many crises in the world. Why should we care about this one? Well, currently we don't. In terms of our spending on non-communicable diseases, It is very low in the US. We spend about $8.4 billion on global health in 2013. 10 million of that went to non-communicable diseases. That's about 0.1%. It's not much better internationally. According to the Institute of Health Metrics and Evaluation at the University of Washington, we spend 1.3% of global health aid goes to non-communicable diseases. That's very low. So we thought about that and said, well, that's surprising given the burden. But maybe it's because we invest in hard national security concerns. We invest in the global health threats that keep us safe here in the United States or in other high-income countries. Maybe that's why you're seeing so little funding go in. Well, as many of you probably know, but most people don't, that's not actually where our global health aid goes. This is a pie chart of US global health funding, and most of it goes to HIV. It goes to malaria, it goes to nutritional concerns, family planning, neglected tropical diseases. By and large, conditions that their prevalence in Malawi has absolutely nothing to do with their prevalence of those conditions in the United States. We invest in them because we care about those populations and we care about the well-being of those governments and their countries. So with that in mind, we looked at the 49 countries that receive $5 million or more in aid from the United States annually. And we said, well, okay, if we care about these populations and we care about these countries, what does it look like? What are those countries affected by in health? And what we found is, again, taking premature burden, so 59 and younger, that the rate of death and disability from non-communicable diseases in the same 49 countries that we've invested heavily in global health is 6 times higher than the rate of death and disability from HIV in the same countries. The rate of premature death and disability from NCDs in the same countries we've invested in is almost twice as high as the rate of premature death and disability from malaria, TB, and HIV combined. So we also looked at individual diseases and the rate of growth and what it looks like, and the series of figures you see here, and they're all in your report, will show the individual cancers that are rising fastest in these 49 countries. Again, the size of the circles are the burden. Where they fall on the x-axis is what it looks like in terms of their overall burden. And you see in most of these countries, everything is above the line. It's growing fast. This is a bit of a plug. You have the report in front of you, but we actually did an online interactive that has each of the 49 countries individually. And you can see what the rate of growth is, what their burden is. This is just a snapshot of Bangladesh. As you can see, nearly half of Bangladesh premature burden is NCD. Although we also show how much aid is currently given in the US by the US government, which is still the largest donor on global health. We looked at what was spent just in a single year and what was spent in 12 years on NCDs. And what you see in Bangladesh is, I think we spent, it's a little hard to read from here, but about $100,000 on NCDs, and in a single year spent, obviously, millions on global health in that environment. So very low, but I really encourage you to look at that data. Given these global health, the large health impact, what does this look like economically? And of course it matters. It matters because low and middle income countries represent half of the economic growth since the financial crisis. It is, of course, 90% of the world's consumers are in those countries we care. And NCDs, as was mentioned before, people, if you're getting sick younger and being sick for longer, this has economic impacts that reverberate out through the health system. And this shows you when the burden, the death and disability arises, at what age range, and you see it starting to take off in low and middle income countries and people in their mid-30s and on. Again, prime working years for populations. This, of course, reverberates out through health systems, given the scale. It not only affects households, it not only affects national systems, it has a global effect as well. You don't have to take my word for it. Referencing the same data that was referenced in the prior presentation. Just what it looks like for low and middle income countries is by 2030, researchers from Harvard and World Economic Forum estimate that $21 trillion in economic costs will arise just for low and middle income countries from non-communicable diseases. So it has a big impact. And again, if we are invested in global health in these countries because we care about their populations and their government, we should care about NCDs. So how do you all fit into this problem? We talked about whether this is a crisis, whether this is something the US and other intergovernmental institutions and other donors should be invested in. What is the role of the academic community? What is the role of the private sector in addressing this? So first, in terms of when I talk about frugal and reverse innovation, what do I mean? I'm talking about technologies, services, processes designed for impoverished populations or health systems serving impoverished populations with very limited infrastructure. The reverse side is just technologies developed for one setting that move more globally. In terms of reverse innovation, that's a little bit of a broader use of the term than many people use. Many people talk about innovations coming from low and middle income countries to high income settings. I think that's a little pejorative to refer to reverse in that sense, as if there hadn't been this transfer of technology in that direction before. So we looked at the problem a bit more globally. These are things you've heard about. They're ICT-enabled healthcare using peer groups or community health workers to diagnose and deliver services more cheaply. Subscription-based phone services to provide healthcare in low infrastructure settings. They're low-cost, durable technologies that whether it's, in this case, it's a sonogram, but you've probably all heard of the baby warmers and other technologies to provide that service. Or it's low margin, high volume, standardized care, such as is being provided around cancer in India and other settings. All these are examples that one might look at in the setting. Why does this matter? Well, it matters because as countries shift to moving away from the acute care that has been historically provided in low and middle income countries for infectious diseases, around child or maternal health care, as you move to that to more chronic care system, we need, of course, lower cost and better technologies that can be provided efficiently in those settings. But it's more than that. The possibility of these technologies or business models also being transferable to high-income settings provides an important incentive for business investment. It provides an important incentive for donors to invest in the development of these technologies. And what I think a lot of people don't necessarily appreciate, what we often hear is, well, the NCD problem is terrible in low and middle income countries, but it's really about governments adopting regulations. It's about policy. It's not about aid. It's not about technology. It's about better policies. That turns out not to be true. So one of the things that we did in this health affairs study mentioned is, as some of you may know, the World Health Organization has adopted a goal. The goal is to reduce premature mortality from the 4 major NCDs, so cardiovascular disease, diabetes, chronic respiratory illnesses, cancers, by 2025, to reduce the adult premature mortality, and they look at populations between 30 and 70. So to do that in 13 years. So what we did is we looked at, okay, what about countries that have achieved that level of performance? How did they do it? And what you find is almost none of them, or very few of them, have done it through prevention. What you see it associated with is economic growth. Now, some of that is wealth, but there's a pretty strong correlation between economic growth and health spending. So the way we read this data is that this is strongly tied to the provision of clinical prevention and care in these settings. There certainly are some modifiable risk factors that matter a lot, and tobacco is by far and away most among them. Household air pollution ends up having a large effect. I don't mean to diminish efforts to address physical inactivity or obesity or excessive sodium consumption. This is just to point out that when we say that low and middle income countries should do all those things and they don't need our aid, we're asking them to do something that we never have done. And what you find is the opportunities to reduce premature mortality or morbidity from NCDs, if they're going to follow what has been done, is really around clinical prevention and treatment and a few very key modifiable risks, tobacco being by far and away the biggest. How big is this opportunity, or how big is the challenge? So one of the things we looked at is, what would it take, what is the level of economic development you need to see for countries, low and middle income countries, just to achieve the health performance that high income countries had in the 1950s? And when you look at the level of economic development to achieve that level of performance for child and infant mortality, the good news is poorer and poorer countries have been able to do this. That's great. The cost has reduced, and the ability to achieve just what we had in high-income countries achieved in the 1950s is becoming significantly more plausible for a greater number of countries. The reverse is happening on adult health. It is you need to have a higher and higher level of economic development just to achieve what high-income countries had in the 1950s on adult health performance. And I should point out, this chart controls for HIV. That is not HIV. That is primarily NCDs. How big is the opportunity? As part of this task force report, we looked at just trying to ballpark what is possible by doing more. And what we did is we estimated, using UN data, what the adult population will be in countries, what their current rate of NCD growth is, other demographic factors to come out. What is this like if there's no real improvement in low and middle income countries between now and 2030, what is their death rate likely to look like? And then we looked at what would happen if they had the rate of improvement of an average high income country now, between then and now. And what you find is that, not even the US. In the US, in some areas we do well, in some areas, as you know, we don't do well, but just the average high-income country. And the difference is 12 million lives. That's what's possible. And that's what the kind of work that you all are doing is to look at what piece of that we can achieve and what can be achieved in a scalable, affordable way. And I congratulate you on that, and thank you for this opportunity to speak.
Excellent. Thank you, Tom. It's always a thought-provoking presentation, and I have the good news to announce that we are right on time. So I think we should take maybe just 2 or 3 questions and then move on. There's a mislabeling in the program. It says break, but it's not a break. It's a chance to start looking at all the interesting, fascinating posters and fascinating demonstrations. Posters you can see some of. The demonstrations are hidden behind, and it's going to take all your break and all your lunchtime to absorb how much information is in the side of this room. So with that in mind, let's take a couple of questions for Tom, and then move on to the next piece of work.
That was a really thought-provoking conversation. It's very difficult to get people their head around the idea of managing cancer in the context of NCDs. And when we measure cost, it's a surrogate measure for organization. There's some things that can be done at very reasonable cost, and some countries like Uruguay have been successful in using resources well. But what is very difficult to do in cancer, most cancers, is doing cancer without cancer centers, without centers of excellence, a focus placed where you can receive treatment. Cervical cancer might be something, or tobacco control, that can be done in a distributed fashion. How should we be thinking about cancer centers, the creation of this type of organization and triage systems that in this context of NCDs? Are other NCDs thinking about centers of excellence, or is that really specific to us?
Not at all. And I should say, the way the report is organized, and if you, people who haven't had a chance to read it, I do recommend it, but we look at 3 baskets. What is possible now, what requires more investment but is foreseeable, and areas for lower middle income countries and high income countries and private sector and academia really to work together, because certainly in high income countries this is not a problem we have solved. But on the cancers, you've identified the ones that are shovel-ready now. The vaccine-preventable cancers, tobacco control, all these, we have a, certainly not perfect, but a better idea of how they can be done, and in the context of cervical cancer, how that can be done, also providing some associated services. There are some cost-effectiveness analyses out there. There's not a lot in other areas. So we did talk about, and the report does recommend investing in cancer registries and investing in these centers of excellence as a way of starting to do that. In terms of how this fits within the overall NCD conversation, a lot of it is about how can we integrate this into existing global health investments. PEPFAR program funds or operates in many settings the largest chronic care platform in low-income settings. There has to be some opportunities to leverage that, and there's a lot of work to be done. There's also the possibility of how do we link institutions. The White House recently announced an initiative to look at this around cancer pathology as a way of providing this through telepathology as a way of doing that, and there's other looks at can we at least link centers of excellence, but it is a topic that we cover in the report and one that you need to see more on, for sure.
I'm Saleh Rahman again. I'm Professor of Public Health and Medicine from Florida. I would like to follow up that question. I direct a P20 Center of Excellence for Cancer Research, and particularly I direct the community prevention and control part in Florida. But my question related to global health, I'm also a native from Bangladesh, the country that you projected here, and work with Christopher Murray on the global disease burden type of measurement. My question is, this is the challenge. We are trying to develop something called a national surveillance system in Bangladesh. And as you see, from USA, I'm a professor here, I'm trying to take any kind of infrastructure or anything that's possible to develop a surveillance system, collaborative process with the local government. With 100,000 or even 1 million, it's not possible, 165 million people living in 55,000 square mile area. So my question is there any future hope or direction that funding-wise that we can seek through US institutions and take it to the country like Bangladesh?
Yeah, great question. I have to admit, when we started this project, I was had a good sense that this would be a problem, although I had no idea. We actually told all the participants of the task force they could say no. And I will say some of the members came in thinking this shouldn't be an area of investment. I think when you dive in the data, it becomes really hard to justify our current global health investments. When you see how much of the premature burden is tied to cancers and other non-communicable diseases in the same communities we're investing in, it's a scandal. It's hard to justify the way that our investments go currently. We did a lot of work around promoting this report. We're obviously still doing it. I spoke to 40 different congressional offices around this report, every executive branch agency, including the White House, around this report. We testified before the Senate around it. I think there's space. I am not as pessimistic as I was before. I think we will see something, whether it's the more demand and data-driven approach to global health that we need, or it's an ad hoc picking up of women's and children's cancers and a few other areas, I can't say. But I'm not nowhere near as pessimistic as I was when I started this process.
And Singh, Stanford Cancer Institute, thank you so much for the excellent presentation. This is related to the two previous comments. I think two important pillars in cancer prevention and cancer control are actually fairly lacking and insufficient in low-resource setting countries, and that is pathology and cancer registry, especially population-based cancer registry. In Africa, actually, they are limited population-based cancer registry. And so I think this is something that we can work together. And in fact, yesterday we were funded to conduct cancer registrar training in Accra, Ghana in June. So if there are anyone from West Africa region interested in participating in this workshop, we'll be happy to train. And also we're hoping to continue to use this as a center of excellence to train more cancer registrars and also cancer prevention manpower in West African region. And so hopefully we will be able to have more interaction and communication at this workshop. And thank you so much for all of the data. I think evidence-based data and data-driven sciences are very important for us to continue for cancer prevention in low-resource setting countries. Thank you.
I thank you for that. I think it's critical, it's incumbent on all of us, given the limited amount of funding, that we find a way to work together. On the pathology side, I just want to point out Blair Holliday, who is both the energy and the brains behind that White House initiative on pathology, is here, and I would direct you to him to talk about that work. But we have to find some way to try to work together on these issues.
Hi, Bob Hyatt, UCSF. Thanks for the presentation as well. I wonder if your committee considered the role of building research capacity within the low and middle income countries as a part of the challenge. So I'm speaking of developing research capacity by native peoples within countries that have the problem, that may have a better perspective on the issues and solutions to them than we might from other high-income countries.
Great. Not enough is a quick answer. We do flog a bit the MEPI program, which, as you may know, is run out of NIH with Fogarty and the PEPFAR program, and it's about trying to use some PEPFAR dollars to build research capacity in low and middle-income countries. But it's a crucially important issue. As I mentioned at the outset, the burden doesn't look the same. There was a question for the previous presentation, what would you do differently? And the two things I would say that I think have hurt the NCD movement is that we've looked at this problem globally, equating the problems of Denmark with the problems of Uganda on NCDs, and I think that's a mistake. We also, I think it's really crucially important to look at premature morbidity and mortality, not because the other concerns don't matter. We certainly have an aging population. But when you start looking at low and middle income countries and premature death and disability, this looks a lot like other global health problems, where it's driven by inequity, poverty, and lack of access to widely available treatment and clinical prevention services in higher income settings. And that's, in my view, would be a way to frame the NCD problem. I think we'd get more traction.
Sherry Wren from Stanford. It was a really interesting report. I'm curious, cancer crosses so many different fields.
Yeah.
And did your group at all speak about the lack of access to surgical care, which is actually the primary treatment for many cancers?
Yeah. Not specifically, but it does cross the lines. You're exactly right. A lot of it is, whether it's surgical care or pathology services or other health services that you see, the lack of investment in shifting healthcare systems from acute care to chronic and preventative care crosses all those lines. And because cancer is so dependent on some of these services more than some of the other NCDs, it's definitely a larger problem there. But we didn't focus specifically on surgery, but it's a good point.
So it's funny because, it's funny because your data looks a lot like what the injury data looks like for the world. And if you look at NCDBs and just add in the word injury,
Yeah.
as everybody's becoming more urbanized and more vehicles on the road, that explosion in deaths, 90% injury deaths now are in low, middle-income countries.
Yeah.
So there's some synergy there.
No, absolutely. I think on the treatment side, there's a lot of synergy. There's less on the prevention side, which is why we didn't include in the report, but certainly on the surgical and trauma care.
I think we're pretty committed to staying on time. We do have the misnamed break. Tom's going to be around. Please ask more questions. And I'll say, having spent a lot of my life doing emergency medicine, I'm totally for the WHO including violence and injury as an NCD now. And you know, one of these cross-cutting approaches to recognize how much all our specialties are interdependent is really being endorsed by putting that on the list as well. I think there's a lot to talk about. Having said that, 4 years ago this started as a speed dating concept. I want everybody to talk to somebody that they don't know. I know there are a lot of us in the room who know a lot of us in the room, but I don't think anybody knows everybody. And let's make sure that we learn from each other by visiting the posters, visiting the demos, and using our time together to realize how much we have in common, how many partnerships could grow out of a meeting like this. Thank you very much. Thanks again, Tom.